These four conditions represent complex cyanotic lesions that fall outside the classic 5Ts, but demand equal attention in neonatal care. Ebstein's anomaly results from arrested tricuspid valve delamination, producing atrialization of the right ventricle and often severe tricuspid regurgitation. Its neonatal importance lies in the potential for functional pulmonary atresia and ductal-dependent pulmonary flow. Pulmonary atresia, particularly with an intact ventricular septum, produces a spectrum from hypoplastic right ventricles to coronary artery dependence, requiring immediate prostaglandin support and careful anatomic assessment. Single ventricle variants encompass multiple anatomic pathways where one ventricle must support both circulations, mandating staged palliation culminating in a Fontan circuit. Double outlet right ventricle is a heterogeneous group where both great arteries arise from the right ventricle, and physiology depends on ventricular septal defect location and associated obstructions. What unites these lesions is their shared management challenge, balancing systemic and pulmonary circulations in a fragile newborn. Early stabilization, maintenance of ductal patency, and precise imaging guide, whether the strategy is biventricular repair, single ventricle palliation, or, in select cases, transplantation. Ebstein's anomaly is defined by failure of the tricuspid valve leaflets to delaminate from the right ventricular wall during development. The septal and posterior leaflets are displaced apically, tethered into the ventricle rather than inserting at the atrioventricular junction. This creates the hallmark finding of an atrialized portion of the right ventricle, which functions more like atrium than ventricle. The anterior leaflet is often redundant and sail-like, further contributing to valvar dysfunction or even right ventricular outflow obstruction. Dysplasia of the valve tissue compounds the defect, with thickened or fenestrated leaflets producing variable degrees of tricuspid regurgitation. The severity of leaflet displacement and regurgitation defines the clinical spectrum, from mild asymptomatic disease to catastrophic neonatal presentations. In severe forms, the functional right ventricle is markedly reduced in size, and the right atrium plus atrialized ventricle dominate the cardiac silhouette. Massive cardiomegaly, sometimes filling the entire thoracic cavity, is a striking radiographic feature in newborns with severe Ebstein's anomaly. The pathophysiology of Ebstein's anomaly is driven primarily by severe tricuspid regurgitation. With each contraction, blood is ejected retrograde into the right atrium rather than forward to the pulmonary artery. This volume load leads to striking right atrial dilation and elevated atrial pressures. When right atrial pressure surpasses left atrial pressure, shunting across a patent foramen oval or atrial septal defect becomes right to left, producing systemic desaturation and cyanosis. The effective right ventricular chamber is small because much of the cavity is atrialized and non-functional, limiting forward output. In the most severe neonatal cases, this can result in functional pulmonary atresia despite a structurally patent valve. Elevated pulmonary vascular resistance and poor contractile efficiency prevent antegrade pulmonary flow, rendering circulation ductal dependent. Beyond hemodynamics, conduction system abnormalities contribute to morbidity. Up to 1/5 of patients have accessory pathways, most often Wolff-Parkinson-White, predisposing them to supraventricular tachyarrhythmias and, in rare cases, sudden death. Thus, the physiology reflects both impaired forward right-sided output and arrhythmic risk, with severity determined by the balance of regurgitation, shunting, and right ventricular size. The clinical spectrum of Ebstein's anomaly is remarkably broad. At the neonatal end, severe cases present within hours of birth with profound cyanosis and respiratory distress. These infants often demonstrate functional pulmonary atresia, where severe tricuspid regurgitation combined with elevated pulmonary vascular resistance prevents forward pulmonary flow. Circulation becomes ductal dependent, and prostaglandin infusion is frequently required to sustain oxygenation. Massive cardiomegaly may be evident on exam and imaging, with signs of right-sided heart failure, including hepatomegaly and poor perfusion. Milder forms manifest later in childhood or adulthood. Exercise intolerance is common, reflecting limited forward cardiac output. Arrhythmias emerge as a major feature, particularly atrial fibrillation and tachyarrhythmias associated with Wolff-Parkinson-White pathways. These rhythm disturbances not only cause symptoms, but also raise the risk of paradoxical embolism in the presence of an atrial-level shunt. Some individuals remain asymptomatic into adulthood, only coming to attention through incidental findings or evaluation for palpitations. The variability underscores that the degree of valve displacement, regurgitation, and right ventricular function directly predicts when and how the disease will declare itself. The exam findings in Ebstein's anomaly reflect both impaired right-sided function and altered flow dynamics. Cyanosis is present when right atrial pressures drive shunting across an atrial communication. The characteristic auscultatory finding is a holosystolic murmur of tricuspid regurgitation, best heard at the left lower sternal border. The second heart sound is widely split, with a diminished pulmonary component due to reduced forward flow across the pulmonary valve. A gallop rhythm with audible S3 and S4 signals volume overload and diastolic dysfunction. Hepatomegaly develops from chronic right-sided congestion, particularly in neonates with severe regurgitation. Abnormal valve leaflet motion may also generate additional clicks, particularly when the anterior leaflet is redundant or sail-like. Taken together, these physical signs point toward marked right atrial dilation, ineffective ventricular contribution, and significant regurgitant volume, providing bedside clues that correlate closely with the underlying anatomy. Radiographic findings in Ebstein's anomaly are among the most striking in congenital heart disease. Severe cases show massive cardiomegaly, often producing a balloon-shaped silhouette that fills most of the thoracic cavity in neonates. The cardiothoracic ratio commonly exceeds 0.7, reflecting the extreme enlargement of the right atrium and atrialized ventricle. Right atrial enlargement is the dominant contributor, giving the cardiac shadow a rounded globular configuration. Pulmonary vascular markings are typically decreased because forward flow into the pulmonary artery is limited. In extreme cases, the contour can appear box-shaped, with straightened borders from the dilated atrial chambers. This dramatic radiographic appearance serves as an important diagnostic clue. A disproportionately enlarged cardiac silhouette in a cyanotic neonate should prompt consideration of Ebstein's anomaly, particularly when accompanied by diminished pulmonary vascularity. Several associated conditions shape risk and management in Ebstein's anomaly. Accessory atrioventricular pathways are common, with Wolff-Parkinson-White syndrome in roughly 10 to 20% of patients, predisposing to supraventricular tachycardia and occasionally life-threatening events. An atrial septal defect is present in most patients, frequently around 80%, which permits right-to-left shunting and increases the risk of paradoxical embolism. Pulmonary stenosis or atresia may coexist and further limit antegrade pulmonary flow. Left-sided cardiac lesions occur less often, but can add afterload or valvar burden. Other conduction disturbances emerge over time, including atrial fibrillation and atrioventricular block. Because of the arrhythmic substrate and interatrial shunting, there is a recognized risk of sudden cardiac death, so rhythm surveillance and pathway evaluation are routine parts of care. Medical therapy for Ebstein's anomaly targets heart failure symptoms and arrhythmia burden. Diuretics relieve systemic congestion by reducing right atrial and hepatic venous pressures. Angiotensin-converting enzyme inhibitors lower afterload and may improve forward flow, especially when ventricular dysfunction is present. Arrhythmia control is often necessary, with beta blockers or class 3 antiarrhythmic drugs for supraventricular tachycardia. In refractory cases, catheter ablation can be considered, though procedural risk is higher in small infants. Anticoagulation is indicated when atrial arrhythmias or marked atrial enlargement create a substrate for thrombus and paradoxical embolism. Surgical intervention is considered for progressive symptoms, recurrent arrhythmias, or evidence of right ventricular dysfunction. Tricuspid valve repair, most often with a cone reconstruction, is preferred when anatomy permits and can significantly restore competence. Valve replacement remains an option when repair is not feasible. Right ventricular plication reduces the atrialized portion of ventricle, improving contractile efficiency. Closure of an atrial septal defect is often performed concurrently, balancing the need for decompression against the risk of worsening cyanosis. Timing of surgery varies. Neonates with severe forms may require early palliative strategies, while older children with milder disease may be managed medically until functional decline or arrhythmic complications emerge. The long-term outlook for Ebstein's anomaly is highly variable and shaped by the severity of tricuspid displacement, degree of regurgitation, and size of the functional right ventricle. Patients who undergo valve repair generally achieve better results than those requiring valve replacement, as native valve preservation maintains growth potential and reduces prosthesis-related complications. Neonatal surgery, while sometimes unavoidable, carries higher operative risk and often necessitates staged or palliative strategies rather than definitive repair. Even with successful repair, reintervention is common, and many patients undergo multiple procedures over their lifetime. Advances in surgical technique, especially the cone reconstruction, have significantly improved long-term survival and functional outcomes in children and adults. Despite these gains, arrhythmia management remains an ongoing issue as atrial enlargement and accessory pathways predispose to tachyarrhythmias throughout life. With modern care, many patients achieve sustained survival and functional capacity, but lifelong cardiology follow-up is essential. Arrhythmias remain a dominant feature across the lifespan in Ebstein's anomaly. Even after valve repair or replacement, atrial enlargement predisposes to atrial tachycardia and fibrillation, while accessory pathways sustain the risk of supraventricular tachycardia and Wolff-Parkinson-White physiology. These rhythm disturbances can occur decades after surgery, making lifelong surveillance mandatory. The timing of repair strongly influences outcomes. Neonatal operations are often high risk and usually palliative rather than definitive. In contrast, children and adults undergoing cone repair later in life generally achieve superior survival and lower reintervention rates. This ongoing arrhythmia burden, combined with surgical timing considerations, defines the long-term clinical trajectory. Pulmonary atresia is not a single entity but two distinct categories with very different physiology. Pulmonary atresia with intact ventricular septum is a unique lesion where no forward flow crosses the pulmonary valve. The right ventricle may range from near normal to severely hypoplastic, and coronary artery abnormalities or ventriculo-coronary connections are frequent. This form is often the more complex because management must account for the adequacy of right heart structures and potential coronary dependence on right ventricular pressure. In contrast, pulmonary atresia with a ventricular septal defect represents the extreme end of the tetralogy of Fallot spectrum. Here, the right ventricle typically is well developed, but pulmonary blood flow is entirely absent without collateral circulation or ductal flow. These two categories demand distinct strategies. PA with intact septum often requires nuanced decisions about single versus biventricular pathways, while PA with VSD follows the physiology and surgical planning of tetralogy variants. Pulmonary atresia with intact ventricular septum is defined by complete obstruction at the pulmonary valve, preventing forward flow into the pulmonary artery. This anatomy forces circulation to depend on ductal patency and atrial level shunting. The right heart structures display wide variability. Some infants have nearly normal right ventricular size, but many present with a severely hypoplastic chamber, and intermediate forms are common. Prognosis and surgical strategy hinge on the adequacy of this ventricle and its ability to support pulmonary circulation. Coronary artery abnormalities occur frequently, most notably ventriculo-coronary connections that can create a right ventricle-dependent coronary circulation. In such cases, decompressing the ventricle may critically impair myocardial perfusion. The tricuspid valve is rarely normal. It may be stenotic, adding inflow resistance, or regurgitant compounding volume load on the atrium. This constellation makes PA/IV as one of the most complex neonatal lesions, requiring careful definition of right heart anatomy and coronary status before determining a management pathway. A defining feature of pulmonary atresia with intact ventricular septum is the high prevalence of ventriculo-coronary connections. In some infants, the coronary arteries become dependent on the elevated pressure within the right ventricle for perfusion. In this scenario, decompressing the ventricle during surgery or catheter intervention can abruptly lower coronary pressure and precipitate myocardial ischemia or infarction. Recognition of right ventricle-dependent coronary circulation is therefore a critical step in preoperative evaluation. Its presence often excludes the possibility of biventricular repair and instead directs the team towards single ventricle palliation. This coronary factor is one of the most important anatomic determinants of prognosis in PA/IVS. Infants with pulmonary atresia and intact ventricular septum present at birth with profound cyanosis, reflecting absent antegrade flow across the pulmonary valve. Because pulmonary blood flow is entirely ductal dependent, immediate initiation of prostaglandin infusion is essential to maintain survival. On auscultation, the second heart sound is single and accentuated, lacking a pulmonary component. Murmurs may be absent if tricuspid regurgitation is mild, which makes the single loud S2 an important diagnostic clue. Chest radiography shows variable cardiomegaly, often caused by right atrial enlargement, and pulmonary vascular markings are diminished because forward flow does not reach the pulmonary arteries. Electrocardiography typically demonstrates left axis deviation and evidence of right atrial enlargement, a pattern that helps distinguish PA/IVS from other cyanotic lesions in the newborn. Taken together, these findings of severe cyanosis, unresponsive to oxygen, single S2 ductal dependence, and decreased lung markings define the clinical picture and highlight the urgency of prostaglandin therapy and early anatomic delineation. Management begins with immediate stabilization. Prostaglandin infusion is required to maintain ductal patency and sustain pulmonary blood flow. If the atrial septum is restrictive, balloon atrial septostomy may be performed to improve mixing and decompress the right atrium. Once stabilized, the surgical pathway is determined primarily by right ventricular size and function. In infants with an adequately sized right ventricle and competent tricuspid valve, a biventricular repair is possible and may include pulmonary valvotomy or transcatheter valve perforation with subsequent dilation. When the right ventricle is severely hypoplastic or when coronary circulation is dependent on high right ventricular pressure, univentricular palliation with staged Fontan pathway becomes the safer strategy. For intermediate cases, a 1.5 ventricle repair can be considered, directing superior vena cava return to the pulmonary arteries while preserving some right ventricular contribution. Careful assessment of right ventricular dimensions, tricuspid valve morphology, and coronary anatomy is essential before deciding on the definitive approach. Single ventricle physiology represents a broad anatomic spectrum where only one ventricle is functionally capable of supporting the circulation. The most common form is double inlet left ventricle, where both atrioventricular valves connect predominantly to the left-sided chamber. Less common is double inlet right ventricle, where the morphologic right ventricle receives inflow from both atria. An unbalanced atrioventricular septal defect can also create effective single ventricle physiology if one ventricle is markedly hypoplastic. The hypoplastic right heart complex encompasses lesions with underdeveloped right-sided structures, often in association with pulmonary atresia or severe tricuspid disease. Conversely, the hypoplastic left heart complex includes mitral or aortic atresia with an underdeveloped left ventricle and ascending aorta. Tricuspid atresia or mitral atresia with hypoplasia of the contralateral ventricle represent additional pathways into the single ventricle category. Although anatomy differs, the unifying feature is reliance on a solitary ventricle to sustain both systemic and pulmonary circulations, dictating the need for staged palliation toward a Fontan pathway. All single ventricle variants share key physiologic principles. Blood from both atria mixes completely at the ventricular level, producing systemic desaturation. The single functional ventricle must sustain both systemic and pulmonary circulations, which creates chronic volume load and predisposes to progressive dysfunction. The degree of cyanosis depends on pulmonary blood flow. If obstruction to pulmonary outflow is present, cyanosis is severe and circulation is ductal dependent. If pulmonary blood flow is unobstructed or excessive, cyanosis is less marked, but pulmonary overcirculation and heart failure develop. Chest radiography reflects this physiology. Heart size is variable, but pulmonary vascularity directly correlates with the balance between systemic and pulmonary flow. Electrocardiography helps identify the dominant ventricular morphology. Left axis deviation suggests a left ventricular dominant circulation, whereas right axis deviation indicates right ventricular dominance. The long-term goal for all of these patients is staged Fontan palliation. This sequence of operations ultimately separates systemic and pulmonary circulations, directing systemic venous return directly to the pulmonary arteries and allowing the single ventricle to support the systemic output. Management of single ventricle physiology begins with the goal of balancing systemic and pulmonary circulations. Excessive pulmonary flow can deprive the systemic circulation of output and lead to heart failure, while inadequate pulmonary flow produces profound cyanosis. Preserving ventricular function is central, since the single chamber must sustain the full cardiac workload. Preventing pulmonary vascular disease is equally critical, because a low-resistance pulmonary circuit is required for future Fontan physiology. Optimizing growth and neurodevelopment ensures that infants are strong enough to tolerate staged interventions. Initial interventions are tailored to the direction of imbalance. If pulmonary blood flow is excessive, pulmonary artery banding reduces volume overload to the lungs and protects ventricular function. When pulmonary flow is inadequate, a systemic to pulmonary shunt, such as a modified Blalock-Taussig shunt, is placed to provide reliable pulmonary blood flow. All patients ultimately move toward a staged surgical pathway, beginning with stabilization of flow balance in the newborn period, followed by the superior cavopulmonary connection, and culminating in the Fontan procedure to achieve complete separation of circulations. The pathway to a Fontan circulation proceeds in 3 stages, each designed to gradually separate systemic and pulmonary flows while protecting ventricular function. Stage 1 occurs in the neonatal period and depends on the underlying anatomy. In hypoplastic left heart syndrome, the Norwood procedure reconstructs the aorta and establishes systemic outflow, with a source of pulmonary blood flow provided either by a shunt or a conduit. In other single ventricle variants, pulmonary artery banding may be used to limit overcirculation, or a Blalock-Taussig shunt may be placed if pulmonary flow is inadequate. The guiding principle is to balance circulations in the fragile newborn period. Stage 2, typically performed at 4 to 6 months, is the bidirectional Glenn shunt. Here, the superior vena cava is connected directly to the pulmonary arteries, creating a passive superior cavopulmonary circulation and unloading the single ventricle. This stage reduces volume load and prepares the patient for complete separation. Stage 3, carried out between 2 and 4 years of age, completes the Fontan pathway. The inferior vena cava is routed to the pulmonary arteries, producing total cavopulmonary connection and allowing the single ventricle to serve exclusively as the systemic pump. Because of elevated venous pressures and the risk of thrombosis, long-term anticoagulation is required following Fontan completion. The Fontan pathway has transformed survival for single ventricle physiology, but long-term complications remain frequent. Protein-losing enteropathy develops in some patients, driven by chronically elevated venous pressures and impaired lymphatic return. Plastic bronchitis is another manifestation of abnormal lymphatic flow, producing obstructive airway casts. Arrhythmias are highly prevalent, particularly atrial tachyarrhythmias due to long-standing atrial enlargement and surgical scars. Over decades, the single ventricle is at risk for systolic and diastolic dysfunction, which compromises output and limits exercise tolerance. Despite these challenges, many patients now reach adulthood, but every Fontan survivor requires structured, lifelong cardiology care to monitor for these complications and to determine candidacy for advanced therapies, including transplant, if function deteriorates. Double outlet right ventricle describes a spectrum of malformations in which both great arteries arise predominantly from the right ventricle. Because of this arrangement, a ventricular septal defect is always present and serves as the only outlet for left ventricular blood to reach the systemic or pulmonary circulation. The relationship between the great vessels and the location of the septal defect defines the physiology. A subaortic ventricular septal defect is the most favorable configuration because blood from the left ventricle flows directly into the aorta. In contrast, a subpulmonary VSD, also known as the Taussig-Bing anomaly, directs left ventricular output toward the pulmonary artery and mimics the physiology of transposition of the great arteries. A doubly committed VSD lies just beneath both great arteries and allows some balance of flow. A remote VSD, separated from the arterial valves by a long muscular tunnel, is the most complex arrangement and creates significant outflow obstruction with circuitous flow patterns. These variants illustrate the broad anatomic spectrum encompassed by DORV and highlight why classification by VSD location is essential to predicting physiology and surgical strategy. The clinical expression of double outlet right ventricle depends entirely on the location of the ventricular septal defect and any associated obstructions. When the defect is subaortic, the physiology resembles a large ventricular septal defect, with left to right shunting and signs of pulmonary overcirculation. A subpulmonary defect, or Taussig-Bing anomaly, directs left ventricular output into the pulmonary artery and produces physiology nearly identical to transposition of the great arteries, often with profound cyanosis. When pulmonary stenosis is present, the circulation mimics tetralogy of Fallot with variable cyanosis depending on the severity of obstruction. Chest radiography does not have a uniform pattern in DORV. The cardiac silhouette and pulmonary vascularity change with the underlying physiology. Enlarged pulmonary markings accompany overcirculation, while diminished markings appear with outflow obstruction. Cyanosis is likewise variable, reflecting the balance of mixing and resistance across the circuits. In practice, the heterogeneity of findings means that imaging and clinical features must be interpreted in the context of the specific anatomic variant to guide diagnosis and early management. The overarching goal in managing double outlet right ventricle is to achieve complete separation of systemic and pulmonary circulations whenever anatomy permits. Biventricular repair is preferred if the ventricular septal defect can be aligned to direct left ventricular output into the aorta. This often involves closure of the defect with a patch that channels flow appropriately. In subpulmonary defects such as the Taussig-Bing anomaly, an arterial switch procedure may be required to establish correct ventricular arterial connections. For more complex cases with outflow tract obstruction, the Rastelli operation provides a pathway by routing left ventricular blood to the aorta through the septal defect and placing a conduit from the right ventricle to the pulmonary arteries. When anatomy is unfavorable for any of these reconstructions, single ventricle palliation becomes necessary, with staged procedures culminating in a Fontan circulation. Surgical decision-making is therefore highly individualized, guided by the relationship of the great vessels, the location of the septal defect, and the presence of outflow obstruction. Repair of double outlet right ventricle requires meticulous planning because of the variability in anatomic relationships. Preoperative imaging, often including three-dimensional echocardiography or CT reconstruction, helps define the spatial orientation of the ventricular septal defect, great arteries, and outflow tracts, which guides the operative approach. Many patients undergo staged or multiple procedures, as initial palliation may be followed by definitive repair once the child is larger and physiology more stable. Conduits are frequently necessary to establish continuity between the right ventricle and pulmonary arteries, particularly in Rastelli-type operations. These conduits have limited durability, making conduit replacement during long-term follow-up a predictable part of care. Surgical results are best when anatomy is favorable, with subaortic defects and minimal obstruction allowing straightforward biventricular repair. More complex arrangements, especially those with remote VSDs or significant associated anomalies, carry higher surgical risk and often necessitate individualized strategies. Long-term outcomes in double outlet right ventricle are determined by anatomic subtype and chosen repair. When anatomy allows biventricular repair, survival is favorable, but most patients still require reintervention. Conduit-based procedures, such as Rastelli repairs, almost always necessitate conduit replacement as the child grows or the prosthesis degenerates. This creates a predictable cycle of multiple operations during childhood and adolescence. In more complex cases requiring single ventricle palliation, outcomes mirror the long-term course of the Fontan circulation. Modern surgical strategies and better perioperative care have significantly improved survival, yet lifelong surveillance is required to monitor conduit function, arrhythmia risk, and ventricular performance. Several imaging features serve as rapid bedside clues to complex congenital lesions. In Ebstein's anomaly, chest radiography reveals massive balloon-shaped cardiomegaly with a cardiothoracic ratio often exceeding 0.7, reflecting right atrial and atrialized ventricular enlargement. Pulmonary atresia with intact ventricular septum produces diminished pulmonary vascular markings, since no forward flow reaches the lungs, and heart size is variable depending on right atrial dilation. Single ventricle physiology has no uniform pattern. Heart size and pulmonary vascularity vary according to whether pulmonary flow is obstructed, balanced, or excessive. Double outlet right ventricle also lacks a single imaging signature. Findings depend on the type of ventricular septal defect and the presence of associated lesions, ranging from overcirculation patterns resembling a large VSD to diminished vascularity in variants with pulmonary stenosis. Recognition of these characteristic radiographic profiles provides an important adjunct to clinical examination and guides urgent echocardiographic evaluation. In Ebstein's anomaly, the hallmark neonatal finding is massive cardiomegaly on chest radiograph, sometimes filling the thoracic cavity. The association with Wolff-Parkinson-White syndrome makes arrhythmia surveillance essential throughout life. Pulmonary atresia with intact ventricular septum is defined by ductal-dependent pulmonary blood flow, so prostaglandin infusion must be initiated immediately at birth. Right ventricular size and coronary anatomy are the key determinants of whether a child can undergo biventricular repair, a univentricular pathway, or an intermediate option. In single ventricle physiology, long-term management is staged over years, progressing from neonatal stabilization to Glenn shunt, and ultimately to Fontan completion. Across all of these lesions, the unifying principle is that survival hinges on early stabilization, careful anatomic definition, and a long-term plan tailored to the unique physiology.